Thank you, Nicholas, for inviting me. One benefit of being the first speaker is that I can ask questions, but I might not have to answer them. And so I can maybe leave the rest of the day with some puzzles and difficulties that might be hard to answer. So let me begin by conveying what we're trying to achieve with an illustration. If we take as a disease diabetes and one of its major complications, which is chronic kidney disease, we have a challenge that a number of patients will develop chronic kidney disease. About 10% of patients do, but which 10%? What I'm describing here is a piece of research that was undertaken as a joint collaboration between two giants using a very large record database. I don't know the size of it, but I know they ended up with nearly 500,000 patients who had diabetes. From this, the analysis studied 300 clinical variables in order to help try to identify which of these, in which algorithmic format, could give rise to a predictor of those most likely to develop chronic kidney disease. The key thing to emphasize about this piece of research, which has been published and is going to be made open and exploited openly, is that it wasn't possible to discover this algorithm and validate it without a substantial data volume. And this is just a typical scenario of where we are today in healthcare, in medicine, in making advances. The opportunity space for us to do this is absolutely huge. There is more and more data available on more and more people. We have almost the concept of digital citizens, people who are existing in a digital space and whose data is potentially available for research and analysis. We are also seeing a growing interest in exciting architectures that can enable this without creating a massive central database. This is a slide example from the IMI Eden project, but I'm using it because it's really a typical example of how Federated works, where the researcher does not have access to a massive central database of patient data, 500,000, 1 million, etc., but rather they author a research query, and the query is distributed by a central platform to a number of health environments that have made a portion of their data, whatever they're comfortable to have shared, is made available in a data warehouse. And the researcher only gets back the query results, the numeric profiling of patients who meet their criteria, and there is no transfer of massive amounts of data. That's a beneficial architecture which is gaining ground. In reality, what we have is more of a hybrid model where there are sometimes central databases at some level. And what you have on this screen is a splash of logos, just to give you a taste of how many initiatives are working on building up some hybrid or fully federated model of how data can be combined at scale to take us forward. And maybe it would be cheeky or completely correct to put the virtual brain cloud somewhere in this space, where it's also working to help advance through data our understanding of neurological issues. However, what we have in practice is something of a spectrum of opportunities where we need to reuse data at the individual level as well as at higher levels of aggregation. This is where health systems and where our learning needs to be. At the level of the individual, at the single patient, there is a huge amount we can offer them if we leverage their own data better, possibly when combining it with the data of others. I'm not going to read through this bullet list, but you can scan it and you can see that there are many opportunities, some of which you know we're doing today, some of which you realize we're barely touching today, but they represent things we could now do. COVID-19 has highlighted the importance of reusing data for public health intelligence gathering purposes, but there are a whole series of things here in the middle that are reusing the data to help refine and improve health systems, public health systems. And of course, you probably all know the many areas, these are just illustrative of where we want to use data for research. So we do have some challenges though on this spectrum. And that is gaining public acceptance, because as we move from left to right, there is decreasing public understanding of why we're using the data and how the data are being used. The number of actors and the kind of actors that are involved in touching the data are increasingly unfamiliar to the data subjects. The use of the data and even the results of the data use are further and further away from the individual patient benefit. It takes longer to get those results, so it's harder to get human societal buy-in because it takes so long to prove that using the data is of value. And of course, people feel less and less empowered as these uses are further and further away from them. How do we trust? To give you an illustration of this, if you look at a survey undertaken just, I think, last year, a European survey looking at how people feel about trusting who can use and access their genetic information. I don't want you to study all of the bars, but just look at the dark purple and the light purple bars. As you move from me personally knowing about my data through to trusting pharmaceutical companies, the distrust level goes up hugely. So we have quite a battle on our hands if we want society to really buy in to the uses of health data at scale to deliver new and exciting benefits. Now, it is difficult because Europe is not coherent in this area. These different infrastructures I showed you a few slides ago, they use different standards. They may define the data they're using with different languages. That means when they combine, sometimes topics like data minimization are hard to implement because everybody's described their data differently. They've got different uses, different terms, and so on. There are a huge number of public attitude surveys taking place. But unfortunately, when you look at those surveys, they vary hugely in how they word the questions. Sometimes when I look at them, I see really clumsy wording, and it's not surprising. They give you results that are very mixed and confusing. COVID-19 has on one level been an important catalyst for society understanding why we need to use data and learn from data, but people have been very forgiving in the COVID era, and we shouldn't assume that their forgiveness remains now a permanent new standard of societal acceptability. And these are some of the real challenges. When we mix with people across Europe who are trying to conduct research on data, what we find is that they struggle. We have on our side of the equation, if you like, on the data protection side, what appears to us to be very clear. There are a set of principles, and flashing up on screen, you see some interpretations of those principles as rules that you're all probably very familiar with. I'm not going to speak to this slide, but this is the instruction manual we give to researchers and say, please now go ahead. It's crystal clear. The GDPR has been developed through major consultations. All use cases have been taken on board. It's good to go. Please use it. But what we find in reality is that researchers, when they're trying to get permission to use the data, really do hit upon inconsistent views. When they want to use a data set for a different purpose, do they need to get consent again? How precisely can they explain the purpose of data use if they plan to reuse it? How minimal, how can they use, define the data they want if they want to cater for the future? What if they want to have updates? What if they would like to be able to get refreshers, but they really don't want to know who people are? Is there a way of anonymizing the data, including rather difficult to anonymize data, so they can get updates but still treat the data as anonymous and not pseudonymized? What if there is a pressure for them to make some of their data open? Open data rules when it comes to data sets at individual level are difficult. There are words in GDPR that suggest, if you like, interpretation. How do we standardize across Europe what that means? When researchers are honorable, how can they prove they're honorable? What can we do to help them to really give confidence to the public and others that they are being good citizens when they use data? How can we prove it? And how can we detect when they're not. And then there are issues around the networking environment. The GDPR doesn't seem to cater for a network effect with data and data users. How do we apply it in these more complicated architectures? And the final call that we've been hearing a lot from industry, from public bodies, from patient organizations, is can we help Europe to be a level playing field? Can Europe really be homogenous so that everybody who wants to make use of data can feel an equal citizen in that opportunity space? Now, the GDPR has a very hard line about whether data is personal or non-personal. If it's not personal, it's sort of out of scope. But we know from research undertaken, this is a photograph of citizens' juries undertaken in the north of England, where there was a deep dive with individuals in the public to help them understand data. Key message coming out of this: if it's anonymized, it's no longer personal. I still care. I still want to know how data are being used. I still care that the data are being used for appropriate, beneficial purposes. Don't think if you've anonymized it, I've lost interest. And that is something we've also seen in an initiative called Data Saves Lives, which is trying to help the public to understand how health data does make a difference. And this is a splash screen of a few example case studies that are online to help the public to see, even when data has been anonymized, that actually it can be used well, it can be used in a responsible way and deliver things that the public would say, yes, I would be happy if this is how data are being used. So this is really the message to give you, that we focus a lot on data protection and making sure that nobody's identified. But actually there is another side to the equation, which is how do we help society to be confident about data being used in the right way? There is no definitive blacklist, but I've worked with a few groups in recent years to try to pull up some examples of things where they say, yes, if there was a set of things that data are being used for that bring societal benefits, that's great. But are there some examples of things that we would all say no to? And this is a list. I'm not going to read you this list, but you can scan it and say, yeah, these are all things that if somebody said, I want to use the data for this purpose, most people would say no, don't do this. This is not acceptable. And we need to maybe consider whether we should be more transparent to the public about reasons why we shouldn't be using data and giving them assurances. These are things where any decision-making body would stop and say, no, you can't use data for these purposes. Is a list like this useful? I don't know. I'm really open-minded. Maybe in the panel discussion, we can debate that. There is no such closed list. There'll be an infinite list, but I wonder if it's useful. So where do we go from here? We've got this challenge that the data protection regulations are really all about the individual. And yet we know that clinical research needs to be using data on populations and delivering back to populations. We know that in general, if you ask the questions in the right way, patients are in favor of their data being used. But actually the GDPR and all of these gray areas have led to, at times, fear. And I was at a conference last week where a patient organization rep was saying that their members are finding that GDPR is breeding more fear in them than it is reassurance. How do we deliver transparency? These are the kind of questions that I feel we need to be exploring. Is there a balance between the individual and society that we need to tease out in more detail? And I would like, if I could, to close with a slide that is really my thought-provoking slide about whether we should be looking for a more balanced approach if we want to scale up how we use data. We do need to bring the public on board even before we start to define the rules. How is data used in ways that really do deliver value? And then from this, work out with them what actually are the elements of trust that would make them be confident and supportive of users, and what are the safeguards that will make them feel that their interests are being protected while society's interests are being advanced. From this, we need to then have ways of assuring our citizens, our patients, that the data have been used appropriately. And that means We need to have transparency in how the data was used, but also transparency in how the data was protected. And this then helps us to communicate benefits. And I just wonder, not sure myself, is this where the GDPR lives, within this set of balancing forces? And does that result in us having a rather limited view on this landscape? Maybe we should not be looking at this through the GDPR window, but more broadly and holistically. That's where I close, and thank you very much for allowing me to present.